easy,
But
right?
okay,
But okay.
can't
All
complain.
right.
What about you?
Welcome, everybody.
Good.
Gosh, thank you so much for being here. I'm glad to see a relatively packed room with so many different places that you could be tonight here at ASCO GU. I'm thrilled that you've joined us here to discuss kidney cancer. One of the things we always promise at these peer review programs is we're going to get right to the core issues. I always love doing these because we really, we don't throw any softballs here. These are all going to be really tough questions for all of our panelists here, and certainly if you in the audience have any questions or comments, we have opportunities for you to jump in as well. We have an awesome, awesome group. Two of my very dear friends are with me here on stage tonight. Dr. Cristina Suarez, who's from Valdebrand, came all the way from Spain to do this program with us. Thank you for that, Cristina.
Thank you very much.
And the amazing Pedro Barata, who I've known for years, over a decade, maybe even closer to 2 decades now. So Pedro, I've known since his training at the Cleveland Clinic, and he's actually gone on to faculty positions at Tulane and has now returned to Cleveland to Case Western, where he's running just a phenomenal kidney cancer program.
Hello. Welcome, everyone. I think
Get out of here. Who is that? Okay. I want to thank a couple of our sponsors for the evening, Aveo, ESI, Exelixis, Merck. Thank you so much for allowing us to put this program together. I think it's going to be a rich opportunity for us to discuss much of the data coming out of the hard work that you've done. And I also want to thank PeerView and the Kidney Cancer Association. I don't know if I can spot my KCA colleagues from this. There they are. They're just grabbing their plates right now. I see Salvo, who's the Chief Medical Officer of the KCA. They do a phenomenal job of broadcasting clinical trial opportunities, research opportunities to patients and providers alike. So for everybody who's here in the room, you can actually use your personal device. I'm going to put a QR code up in just a second for you to respond to all the polls that we put up intermittently during the program today. And if you can, also try to respond to the polls on your screens. Some of you may have screens at home, and enter the answers there, any questions within the chat windows. Sounds like ocean waves in the background, doesn't it? I didn't realize we were that close to the beach.
Wow.
But in any case, if everybody could take a moment to scan this QR code, we'll be using this code to respond to polling items throughout the course of the evening tonight. There's also an opportunity to win a $50 gift card if you respond to the polling option, so we'd really appreciate that so we can have some robust feedback. And please do feel free to visit us at peerview.com/RCCSF26. All the content that you'll see presented today, and there's a lot of really good slides that Cristina and Pedro and others have put together, they're all going to be available there. So we have a couple of goals today. I would say that the number one goal is to really contextualize all of the data that you're going to see coming out at this meeting, and there's quite a bit of it in the field of kidney cancer. Beyond that, we really want to see if we can help you come up with individualized treatment plans for your patients. We'll do that through a variety of case scenarios. And then finally, adverse events. I think that's going to be a big component of what we talk about tonight as well. Just a quick word on the KCA, since they've played such an integral role in putting this program together. They've been around for more than 30 years. I've been to their meetings for, again, probably upwards of 20 years at this point in time. And they do phenomenal work. They provide patient education, support on an individual patient level. I'll put up a little bit later some of the clinical trial finders that they have, which are amazing tools for patients in the clinic. And advocacy. They do a wonderful job making sure that we have the funding that we need to propagate kidney cancer research. So with that, I'll jump into my portion of the talk. I actually probably have one of the more exciting bits of the evening, getting to talk about adjuvant and perioperative therapy, but we're going to launch right into discussion here. I think we all know the need for good perioperative strategies. Those of you in the audience that treat breast cancer and bladder cancer know that these paradigms have been in place for a long time now, but there's certainly a need for us to replicate this in the context of kidney cancer. So what have we done in kidney cancer? These sessions were actually a little challenging, I would say, 5 or 6 years ago, because the only agents that we had at our disposal were TKIs in this context. And we'd had a number of studies. The only study that was, I would say, marginally positive was the S-TRACK study, which led to the FDA approval of sunitinib. I don't know, Pedro, are you using much adjuvant sunitinib in your practice?
Not anymore. I forgot the last time I considered it, to be honest. So
Yeah.
It's been close to a decade, many years.
Yeah. How about you, Christina?
Never.
Yeah. It's one of those things. It's there. It's at our disposal. We always discuss it with patients, but despite the evidence for it, we rarely use it in clinical practice. What's really sort of supplanted it is this trial, Keynote 564. I think this will be well known to many of our members in the audience. So this was a study that randomized patients to receive pembrolizumab or placebo with high-risk renal cell carcinoma. I always like to very quickly review the eligibility criteria: T2 grade 4, T3 any grade, and essentially beyond, including your resected metastatic patients. And this study indeed was positive for disease-free survival, positive for overall survival. It's really hard to argue with overall survival data in the adjuvant setting. But you're really not to be outdone, there was data from the Rampart study that was presented, and this was just at ESMO last year. This was a complicated study that looked at active monitoring versus durvalumab and tremelimumab. And if I could sort of summarize this data in 2 minutes or less, I would say, look, there's a DFS advantage here, right, with durva-tremi versus active monitoring. We don't know the data for durva monotherapy yet, but no overall survival advantages yet, right? That OS data is still immature.
Right.
At this point in time, Christina, maybe I'll turn this to you, but has the durva-tremi data made much of a dent in clinical practice in Europe?
I would say no, not yet, at least with this data, waiting for OS, and we have pembrolizumab, so maybe I could consider, we don't know the data from non-clear cell, just the subgroup, but I would consider maybe for non-clear cell, but not in clear cell RCC, having pembrolizumab.
I think that's a really excellent point. The data for non-clear cell in the Venn diagram between Keynote 564 and Rampart, that's one of the key differences.
Yeah.
Rampart gives us some insight into non-clear cell disease, but we're kind of in the same boat, aren't we, Pedro?
Yeah, no, I agree. I think it's a little bit premature. By the way, we're going to see data at this meeting, right, around Rampart PRO, I believe. So we'll see. Stay tuned for Saturday on that topic. But I think it's premature, as you said, Monty.
Yeah, excellent. Okay, now the really exciting stuff. And I know this is the presentation, one of the two that we're all kind of waiting for on Saturday. This is the LIGHTSPARK-022 study. So if you look at this, the eligibility criteria here are identical, right? To what we see in the context of Keynote 564 for the most part. If you look at the randomization here, it's pembrolizumab with placebo versus pembrolizumab with belzutifan. And that belzutifan is maintained for that entire duration of 1 year that we keep the pembrolizumab going. We know a little bit about this study in terms of the data to date, right? From a press release, we understand that this combination led to a significant and clinically meaningful improvement in disease-free survival, and the study continues on to evaluate overall survival. But as I always like to do here, let's speculate a little bit, okay? You know this data, right? Let's pretend none of us have seen it at this point in time. If we anticipate that there's, as they say here, a clinically meaningful and significant benefit in disease-free survival, but at this point in time, no OS data available, right? Is this going to immediately go into your practice, Pedro? What do you think?
Yeah. So philosophically, we always think, I think the more we know we're not helping patients, the more niche we tend to be. So keeping in mind that we're probably over-treating about half of the patients in this setting. We're going from not half of them or half of the people we see in practice don't actually need any adjuvant, yet we are offering adjuvant IO, trying to cover the other 50%. So we go from half that don't need anything to actually going on treatment intensification with a HIF-2 alpha and pembro. So I would argue that assuming the delta will not be measured in years, which I don't think is expected. I think probably the delta we'll see will be measured in months, which is statistically, if you do some napkin calculations, just look at the stats around the trial. Without OS at this point, I think at best OS will be immature, maybe trending the right direction, but there's not enough events that we would anticipate, right? I don't think I'm going to be offering for most of my patients on Monday, right? I think it's relevant to keep that in mind. There is a little bit of, on other trials, a little bit of data on IO with HIF-2 alpha combo, no VEGF in the metastatic setting, and you always like to think, are we anticipating what we would do in the advanced setting? But until the other pieces of the data, or until we have a biomarker to actually looking for those patients who definitely is a matter of when they recur, not if they recur, it might be a little bit premature for me in the most part. I will allude to it, but it's unlikely I'll be having most of my patients on a combo.
Yeah, I know that, there are a lot of folks in the room hoping to get your insight on this too, Christina. So what do you think? Let's say, you see the data, it matches what's stated here in the press release, right? We won't get more granular than that. Are you going to use it on Monday morning?
So I'm going to say something different, so just to, so I agree with you. So we are overtreating many patients with adjuvant therapy in general, but one thing is, obviously it depends on the magnitude of the benefit in DFS, but also depends on the adverse event profile. So if belzutifan is not adding too much adverse events, I could consider, and especially because I think belzutifan and the HIF-2 alpha inhibitors made more sense at the beginning of the disease, where HIF is really the driver of the disease. So I could consider, I know the data, but we need to see about the magnitude of benefit. And in the end, we used pembrolizumab with no OS at the beginning. So I don't know. I could consider in some patients.
I think those are very valid points. I'll just quickly share my perspective. In case anyone's interested. But what I would suggest is that, in a setting like this, I would probably have the discussion with most patients. But in my mind, I think that it's probably going to be the more motivated patient, perhaps the younger patient, the patient with more aggressive disease characteristics, who's probably going to bite and want to pursue this. Just given the AE profile, as much as I believe in adjuvant pembrolizumab in and of itself, it can be a very long and challenging conversation with the patient in clinic, especially when you spell out to the nomograms that suggest that, the chances of recurrence are moderate at best. Yeah. Okay, so this really lends itself to discussions around something that I think is, worth us talking about, which is what happens to studies in this space. Right? So we have the data for pembro plus minus belzutifan. We know from the press release that it's positive. We've made the assumptions that we did in the last slide that it was truly clinically meaningful. What happens to this study, STRIKE? So this is actually, in my mind, a very important trial. It looks at pembrolizumab plus or minus a short course of therapy with tivozanib. When I say short, it's 6 months, so take that with a grain of salt. But the eligibility criteria here are, again, very similar to the previous study. Pedro, what are your thoughts here? This is a study that we're actively enrolling to.
Yeah.
Should we be shutting it down in the face of 022?
Right. So we have the same. So we have been offering this to a lot of patients. So as you know, Monty, this study is enrolling extremely well, right? Yeah. And so from the moment, if you go back to the adjuvant data, from the moment when it's presented, and you will need some degree of maturity to go to the regulatory agency and get it approved, and after approval, getting available. So there's a delay there, and at best, that delay will be months. We don't know how long it will take us, assumingly that's going to be approved, right? So I would guess by the time it gets available as the new standard of care or as one of the standard of care approaches, this study will be close to be done. It's a large study. It's looking for over 1,000 patients, if I'm not mistaken, on the STRIKE. But at the pace of enrollment, it has been extremely fast, and there's not a lot of competition out there. So I think at that point, you certainly will have half of the trial enrolled, if not 2/3 of the trial enrolled. And so the question that you get at the end, are you going to amend the study, having the conversation statistically about the standard of care, the control group, right, which I think is your question. Do we keep pembro monotherapy, or are we going to allow the addition of bel in addition to pembro in the control group?
So I think you make a valid point, which is that it may in fact be a moot point. By the time this actually hits our clinics, maybe the study will be done. But what if it's not? What if we actually have a landscape where you could offer pembro bel? What does that mean for this trial?
So, I think you raise an important point, which I didn't bring, which has to do with the toxicity. To me, it's not the same to give therapies to patients with or without cancer. They have. The tolerability to handle adverse events is different, right? And there's certainly a learning curve from belzutifan that I think providers out there need to learn. I'm not sure the setting for them to learn is actually this space, in the absence of disease, where the threshold to come off therapy is much lower, if you will. So I do think that conversation and the equipoise, it will be something I would think will require significant conversations to consider amending the protocol, not for a third arm, but it obviously would be to add Bell to Pembro, in my opinion. So I don't think it's a done deal that if it becomes available, automatically the next day we'll see an amendment to change the control to Pembro Bell instead of Pembro.
Yeah, I tend to agree with you. And, a couple of other points too, I think it's meritorious to see whether or not maybe the 6-month interval, gives you a similar extent of benefit as perhaps this more extended duration of belzutifan. In my hands, I think tivozanib's been a very well-tolerated drug. Fairly easy to manage the AE profile of it in clinic. And, it may actually confer some advantage to patients to actually receive this sort of shorter stint of therapy.
And there's one more point, Monty, sorry, which has to do with the safety. I mean, not that we're very concerned, I think you're right, Tivo is a very well tolerated, but I'm pretty sure you'd have to run a safety arm, if you will, or at least you have a number of patients to prove it's safe actually to combine Pembro Bell with Tivo, right? Yeah. We see that with a different combo in the context of the efforts in the advanced setting, but we also have to run the safety period of that study if you were to amend the protocol. It's an additional step towards the amendment of strike. So I think it would make it a little bit less likely, especially if he's enrolling so quickly.
Yeah. Maybe I'll get a European perspective on the same issue. Again, let's assume this trial strike, was happening in Europe and so forth. Would the Len-Bell data immediately sort of bring it to a close, or could we still accrue to a study like this?
So the good thing in this case in Europe is we are so late every time, but by the time we have that combination, it will be closed, the trial. But yeah, I think it's something we should consider and we should discuss with the patients, especially if it's really available and they know they have another option. So
yeah.
Yeah.
I definitely, I definitely think that this is a great, sort of statement to, folks in the room who are involved in research and so forth. I still think there's an opportunity to do Pembro-based trials. We're certainly doing a number of ISTs at our institution that have sort of that Pembro, control arm, plus or minus. I think if we see an OS benefit with this regimen, that might change things a little bit. But, beyond that, I think it's reasonable to keep those studies going. Very good. Well, this has been a good discussion so far. So, just important to keep in mind the goals, in the adjuvant setting. We want to prevent disease recurrence. We want to, however, sort of counterbalance that, as you mentioned, Pedro, and as you've already alluded to, Christina, the concerns around toxicity. There's the financial piece of this, which we haven't discussed so far, which I think is so critical. And of course, these toxicities are a difficult one to balance. When we think, for instance, about, belzutifan in this context, I think many of these, elements might potentially apply. The rates of significant toxicity is relatively low, but there are severe toxicities, the hypoxia, et cetera, that you need to sort of factor into the equation. OS is something that certainly was favorable in the context of pembrolizumab. I guess we need to wait for that data in the context of belzutifan. Okay, great. So we're doing really well with time here. So what I'm going to suggest is that we have a little discussion around this hypothetical case. Christina, I'll ask you about this patient. This individual here has a 13 centimeter right-sided renal mass, pretty obvious there, right? And the patient undergoes right-sided radical nephrectomy. Let's assume no distant metastases. And this patient has grade 3 clear cell renal cell carcinoma. It's ultimately staged as T3A. And you do see that there's some rhabdoid and focal sarcomatoid differentiation. So in this case, let's just break it down. What would you pick for this patient in terms of adjuvant therapy?
Pembrolizumab for sure. So, yeah.
Let's assume that you have pembrolizumab and belzutifan available. Would you offer that to this individual?
Probably yes, because as you mentioned, this is a kind of patient, he's 60-year-old and he has rhabdoid features, so it's a high-risk patient. So I think it's the kind of patient I would go for the highest or the most combination of drugs. So yeah.
That makes sense. And Pedro, how about you, bud?
Well, we haven't seen the data, right? It's not public, so so I think. I probably would offer him a study. We do have strike, so this probably would be my preference. I think we all agree. We probably would lean towards offering systemic therapy, right? So for me, probably would be strike as the default plan at our institution on Monday.
Yeah, interesting. This is certainly a patient where I'd really sort of push them to strongly consider pembrolizumab. But indeed, if I had pembro belzutifan at my disposal, I'd discuss that. I'd have no reservations about putting a patient like this on strike, for instance, if they were willing to take on the risks and benefits therein. But now it's our chance to actually ask you in the audience. So if you don't mind, if you happen to have loaded up that Q&A poll, earlier, and you can see the QR code here. If you could put your response in, we're going to see it pop up in just a second. And just a quick FYI, for the other polls that we do tonight, we won't actually see responses delivered on the screen. Okay, so let's see what we've got here. Okay, so it looks like a lot of people are really enticed by, oh, okay, oh, this is moving. Oh, this is interesting. It's like watching a horse race. Okay. A lot of people enticed by lenvatinib and, pembrolizumab and belzutifan, some suggesting pembrolizumab in this context, some suggesting a clinical trial, some even surveillance in this context. That's an interesting option, and several not sure. So, hopefully we've, done some good distillation of the data here to at least help in this sort of toss-up. Okay, excellent. So before I jump to Dr. Barata's excellent talk, I just wanted to highlight a couple of the resources that the Kidney Cancer Association has to provide. So there's peer-led meetings. I think this is a really outstanding resource. And there's separate meetings, I'll point out, for caregivers and for patients. I think this is really important. There's these huge elements of caregiver fatigue and burden that, families of our patients contend with from day to day. It's great for them to have that forum. But of course, there's some patient-specific concerns as well that I'm sure they want to dwell on. So please visit the Kidney Cancer Association website for some more detail around that. And with that, it's my pleasure to introduce Dr. Pedro Barata, who I actually am proud to say is now an endowed chair at Case Western. It's really awesome. And he directs GU Medical Oncology research there with an illustrious team of other investigators. Pedro?
Thank you, Monty. I appreciate that. Thank you all. We have a busy room, a full house, which is amazing. Talk about kidney cancer. And since you highlight the endowment chair, just to say, actually, is one of my patients with advanced kidney cancer, and he benefited from access to novel therapies, including a HIF-2 alpha. So since we're talking about that tonight, it's pertinent to highlight that. So I'm going to fly through this of what we already know and kind of maybe stop a little bit more on the new things that we'll discuss tonight. So we know where we came from, right? Many of us were around in the context of old immunotherapy, cytokines. Remember the high-dose IL-2, interferon. Then we moved towards the development of different target therapies, bevacizumab first, sorafenib, and then all the TKIs first, second, third generation. And then we're talking about combination strategies, what makes sense. We talk about sequencing a lot, and we brought novel mechanisms of action, and we see how that all pans out. So when we look at the front line, and I'll spend a little bit of time here in the frontline space, the idea was to move forward checkpoint inhibition, and we did that with dual IO, and then we did IO with different combinations. Not all TKIs were good to combine with. Some were not as good and for safety concerns as well. And we end up getting 4 that made it to the practice, and that's basically what we use: Ipi/Nivo, Axi/Pembro, Cabo/Nivo, Lenv/Pem. So I'll focus on those 4. All of them have been we've seen through the years, and the first was actually in 2017, Ipi/Nivo with the Checkmate 214. Here's the data 9 years later, right? Nizar, I believe, and Bob Moser presented these data. It's published as well. You can see consistent data throughout in regards to clinical outcomes. In this case, you're looking at overall survival for a positive, irrespective of the groups you're considering. We know that's also true for the 426 keynote, Axi/Pembro. This was the first IO-TKI to read out by Brian Rini at the time, 2019, I believe. That's where we saw this data the first time, and then different longer follow-up. We are around 5 years or so above that. You see, delta there for tumor control measured by progression-free survival, and then overall survival. We've been seeing robust activity there as time passes, and it's also true with the clear data. Lenv/Pem and Cabo/Nivo were the most recent studies to read out first, so therefore you always, they'll be behind in terms of the median follow-up. We've seen these data, over time. Here we're showing you data for 50 months of follow-up. If you pay attention, is very close to the median overall survival in this patient population, right? Which we're basically getting close to around 4.5 years for median OS, touching the 2-year mark for the combination of Lenv/Pem at the dose of 20 milligrams of Lenv, along with standard Pembro, and finally 9ER, Checkmate 9ER, Cabo/Nivo, and also data there for 68 months follow-up data. Again, PFS and OS, you basically see a delta of around 40-ish% risk reduction for tumor control, PFS, and then around 20 to 25% or so for risk reduction for overall survival. And you'll see the medians again touching that 4-year mark, if you will, the high 40s to close to 50 months. So that's where we are, right? And if you think back, if we were back 10 years ago, those numbers were less than half, right? So we made strikes for these patients. It's not enough, no question, but there's definitely a benefit of considering combination strategies up front. So with that said, just a reminder, at this meeting, we'll have an update by Dr. Suarez, Cristina Suarez. So it's again, the importance of achieving a response. And we do know that. We know that IO-TKI provides perhaps higher response rates, and we do know that the depth of response matters in the long-term outcomes. We've seen that in the past, and this is an updated analysis. Basically patients who achieve a very deep PR, so tumor shrinkage, like 80%, 90%, or even CRs, right, where tumor disappears in the scans that we normally do, achieve the longest outcomes, right? So response matters from that perspective, if you will. So stay tuned. Please stop by, the presentation by Dr. Suarez. This is actually a small effort we put together, at our center, asking the question, well, is this concept of tailor the curve, dual IO versus IO-TKI? So at that time, we have data available at 4 years for all the combos, and what we basically saw, this was kind of fancy statistics. I'm not a statistician myself, but I can tell you basic what we're seeing here is that at 4 years, we basically see a solid, robust PFS advantage from IO-TKI compared to IO-IO. However, that doesn't translate into a difference in overall survival. In other words, at 4 years, taking that as a landmark evaluation, we don't see a difference whether you're thinking of good risk, whether you're thinking of intermediate or poor risk. So from that perspective, I would argue pick your favorite IO-based approach. We can debate the merits and the drawbacks from one versus the others, but the importance is we need to be comfortable with them. Pick one, you probably have your favorite, and use it well. So as we think of that, and we have different mechanisms of action, if you're thinking of a checkpoint inhibitor, if you think of a target therapy, you will see IO-specific adverse events, you will see target therapy-specific safety signals, and some overlapping toxicities, right? So it's important to keep them in mind, and a lot of times, and we learn this as we run these protocols and we do it in clinical practice, what do we do, right? What we do when we have diarrhea, for example, where either therapy can cause that. So in general, because of the shorter half-life for the TKI, in general, we tend to hold it, for example, and understand exactly if that's a TKI-related toxicity or if it's an immune-mediated adverse event. It is just an example. What I would highlight, though, is that we have plenty of resources available to us, whether it's ASCO or NCCN or ESMO, wherever you are, you will have free tools available online, not only for the proactive identification of those adverse events, proactively addressing them, and also the escalation of interventions that you need to do depending on the severity of adverse events. And remember, you categorize them based on CTCAE, which is, again, another free tool online. There's also an app, and the best way to classify those adverse events is just to use the toxicity criteria, if you will. So a reminder as well, as things are evolving, we do have checkpoint inhibitors available in the subcutaneous formulation. Specifically, all the IOs we're using in the frontline, PD-1 inhibitors in frontline, whether it's nivolumab or pembrolizumab, are available in the subcutaneous formulation. And of course, think of whether or not that's something that you want to consider for your patients in regards to flexibility, to no need for IV, in the case that you're doing just the one IO and you're not doing an ipi-nivo, for example. How you handle the logistics at your center is something to be in mind that's available to you and to your patients. So there's a number of trials that may change the landscape, may change the way we think of this setting, the first-line setting. Pedigree, we actually, is an interesting concept. Is kind of a 2.0 version of Cosmic 313. At Cosmic 313, as a reminder, we added Cabo on top of ipi-nivo. We did see a difference in PFS, no difference in overall survival. The approach for Pedigree is slightly different. It's an adaptive design. You get ipi-nivo up front, and in 3 months, depending on the response, either you continue on nivo alone, or you actually randomize to adding cabo on top of maintenance nivo, or you continue nivo. And that's really the question being asked. And patients who progress go on cabo second line. So it's very interesting to see what happens on the part 2. The part 1, Dr. Zeng did a great job showing us what happened in the real world, getting those patients to the 3-month mark where that randomization happens. And then we're going to have a different iteration of different approaches. Perhaps I'll highlight an European effort, CARE 1. I don't know if, Chris, if you have that study running in Spain as well. I know Lawrence is leading those efforts.
Yeah, we're going to start now.
You do?
Yeah.
So it's an interesting concept, right? In all the meetings, we've been debating, should we do ipi-nivo? Should we do an IO-TKI? What do we do? So actually, it's a very pragmatic approach. PD-L1 positive, you randomize, IO-IO, IO-TKI. PD-L1 negative, you randomize IO-IO, IO-TKI. So it's a very pragmatic approach to that question that we ask all the time. And then, of course, evolve. You have a bispecific there, you know, and then the LightSpark-12, which I believe everybody's very excited to see it when it reads out. That will come soon. So thinking of triplet therapies, I think all of us were quite excited when we saw this umbrella keymaker effort, which is basically a pembro-based approach. Chris did an amazing job presenting this data not that long ago. I believe it was at ESMO. And you know, different combos. You have a LAG-3 there, you have a TIGIT there, you have their own CTLA-4, and then the control LENF-PEM, right, for benchmark. And what's interesting to me, at least, you know, you can look at different cohorts in there, but I probably would highlight here the data for the LENF-PEM BEL. And why? Because that's being explored in the frontline phase 3 separately. So I guess this was maybe an early look into what that triplet might look like. It's quite impressive, in my opinion, to see a progression-free survival of 31 months, right? You know, and so of course, given is a smaller study, proof of concept. Nonetheless, we'll see if the addition of a HIF-2 alpha inhibitor adds value to the backbone IO-TKI. So to me, that was one of the interesting highlights of that data. You did an amazing job presenting it, and it's very important to be out there, Chris. So kudos to you for that. So here's the basic what we're waiting. LightSpark-12, as you can see, kind of asks 2 different questions there. You have the control as LENF-PEM, and then, as I said, you know, you have their own CTLA-4 pembro there with LENF, so a triplet, and then the other triplet that I just alluded to with LENF-PEM belzutifan. So the study has completed enrollment. We'll see what happens when it reads out. So before I move on, I'll stop here. Please use your phone for the QR code and try to answer the follow-up polling question about frontline regimen. I'll give you just a few seconds. We will not see the results popping up on the screen, so we'll just keep moving. So just give you perhaps a few seconds here. Just make sure you get the chance to answer that question. All right, and now I guess the second part, I'm just going to show you what I think it's very exciting and coming, and it's going to occupy a lot of our conversations in the near future. So first, let's start with, I think it's one of the most exciting TKIs on the horizon. It's called zanzalintinib. Dr. Paul and Dr. Suarez, Monty, and Chris help with the development of this compound. You know, and it's a pan-target therapy, and it has some advantages, including the fact that it targets VEGFR2, MET, AXL, MER, but also has a shorter half-life. So it gives you the ability to play with that as you offer it in terms of handling toxicity as you offer these to patients. Now, we do know this data. We have data for monotherapy. We have data for combination therapy. Monty did an amazing job to about 2-3 years ago, I believe, when you presented this data, monotherapy, refractory patients, active agent, right? And what's interesting at the time is when you look at the breakdown by exposure to an active, very active TKI like cabozantinib, you can see it still works, right? So, and I think quickly we saw this as we enrolled patients on Zanza's study. I think we quickly saw there was an active TKI. So we saw the data, as you can see here, as monotherapy. At the time, there were clear cell patients. This is what you're showing. Also, non-clear cell enrolled at the time. So you actually, Monty, you were able to generate data also in non-clear cell. I'll get to that point in a second. And then there was this Stellar 2 effort put together, multi-cohort study, different settings. Actually, Stellar-2 has non-clear kidney cancer cohorts as well, like urothelial and prostate. We end up enrolling for those as well. But here, focusing on kidney cancer, you had a frontline, a refractory setting clear cell, as well as a non-clear cell. So a lot of good questions put up here. And on top of asking the question around Zanza, you also bringing therapies that at the time could be deserve the merit of being explored. And I'm thinking of relatitinib, for example, LAG-3 inhibitor. So you see there combination of Zanza with nivolumab, combination of Zanza with ipi/nivo, combination of Zanza with nivo/rela, and that's true in the different cohorts: frontline, refractory setting, non-clear cell. So we've seen these data. Our friend Dr. Jahoud from Moffitt presented these data not that long ago, last year, and we basically looking at the data for the frontline cohort with PD-1 nivo or with nivo and rela, the LAG-3. And I would say that perhaps for me at least the most exciting part of the data was actually the combination Zanza-nivo cohort there, around 40 patients or so. You can see over 60% response rate, very high control rate there, and and also promising, in my opinion, promising PFS and duration of response. So, so I think these ultimately confirm the activity signal, and it led to an effort put together in a non-clear cell arena. It's called Stellar 304. So this is one of the first, actually the first randomized phase 3 trial taking different histologies, papillary, classified, unclassified, and translocation RCC subtypes, randomizing to standard of care sunitinib or the combination of Zanza-nivo. This study has completed accrual. It was a close to 300 patient trial, 2-to-1 randomization, and we are waiting to see what happens with these results. And if positive, I believe it will change practice in regards to the TKI that remains as of today, the standard of care based on the prospective data. Monty helped develop that trial with PAPMET as Cabo established as a very active TKI as well. So we currently use TKIs, and so I believe this data is truly relevant if the trial is positive. So stay tuned to see what happens here. So the other approach that I think you might find is home is a biomarker-based approach, right? We've been struggling to actually find biomarkers of success. This one is a gene expression signature. So you go after RNA, you send it out, you are able to sequence and get a kind of a cluster analysis back. So you have these signatures. These signature evaluation is actually based on another trial called Emotion 150 and 151, and that's published. And you basically find different clusters, and you find the angiogenic signature, and you find inflammatory signature. And basically, this study has an pragmatic approach. Brian Reaney is the PI. I know City of Hope collaborating in Zephyr. We collaborate in Zephyr as well. And basically, patients or tumors with angiogenic signature receive Cabo-nivo. Patients with an inflammatory signature are receiving ipi/nivo. And at ESMO, we saw the results with the Cabo-nivo angiogenic cohort, which is quite interesting to me, proof of concept. Responses over 75% and 0 PDs as best response. So in other words, you are squeezing your IO-TKI in the tumors that are destined to do better. One aspect that I think is also relevant, it was some discordance between the results in the primary tumor and the metastatic site. So this trial actually moved on to take the results or the sequencing data from the metastatic lesions and not from the primary tumor. So there's kind of learning process. To me, is very important as we move forward because we understand the complexity that is. So with that said, I think they prove it to be feasible. A multi-site study, and we're going to wait for the results on the ipi/nivo, which I would imagine I would expect good results as proof of concept. So, but this to me challenges the concept of can we go beyond the clinical factors, the lab factors, and perhaps using genomic alterations to help us decide how to treat. Finally, I have to touch on microbiome. I think we've seen an emergence of this topic, how the impact of the gut microbiome means for patients receiving immunotherapy-based strategies. So this slide probably elegantly summarizes some of the proposed ways by which changing the microbiome or the gut microbiome impacts activity of immunotherapy. Of course, we've all seen data with antibiotics, with steroids, with PPI TKIs, et cetera, right, with fecal transplantation. So today I'm not going to talk about fecal transplantation, but I will talk about a live bacterial product that Monty Paul and colleagues at City of Hope did an amazing job leading those efforts, basically showing us as proof of concept that whether you bring Ipi/Nivo as backbone and you offer Clostridium butyricum, so impacting gut microbiome that way, or if you do it with Cabo/Nivo, you basically enhance the signal, you enhance the activity of the IO-based approach in those patients. There are similar designs, 2-to-1, about 30 patients in each one of the studies. Monty, you end up running a third study, doing an escalation of the dose of Clostridium butyricum, offering to patients, right? And so that data is really, really critical and pivotal and really provocative, right? Because it actually it led us to put together, under the mentorship of Monty and Ulka, out of SWOG NCI mechanism. I'm happy to share with you all that this phase 3 trial is approved. It's going to launch very soon, probably in 2 months. And the idea is to prove whether or not the addition of CBM-588, meaning Clostridium butyricum at the dose found by Dr. Monty Paul's study, really enhances the activity compared to backbone or to the control IO-based approach. And as you can see, a progression-free survival is the endpoint for this trial. It's around a 700-patient trial, so it's the approved iteration of this trial. So we'll see what happens. If it's positive, of course, I think the implications for the field go way beyond kidney cancer, right? We can imagine all tumors where we're using immune checkpoint inhibitors as part of our management of the disease can be potentially impacted by that. So we're really excited about the fact that we're basically taking these out of the ground and get it going with that. And with that, that's all I have. Stopping. For now, I'll give it back to you, Monty.
That was so perfectly timed, right on time. Excellent job, Pedro. Thank you for that.
Thanks.
Okay, so I promised some hard questions. Okay, so we're going to get right to it. We're going to start maybe with a more straightforward scenario. Let's say this is a patient in your practice, 68 years old, with aggressive disease, multiple hepatic metastases. This is something we've talked about in yesteryear, so I'm not going to get too knee-deep in this conversation, but what do you think, Christina? IO-IO or IO-TKI for this patient?
It's a difficult question. So the quick answer would be IO-TKI because the patient has an aggressive disease and a rapid disease. So we need to stop probably with those patients we should just have one shot. Mm-hmm. And we know that IO-TKI have the less progression disease in the fewer progression disease. It's 5%, 5-6% with LMPM and Nivo/Cabo, and 10% with Pembrolizumab. So quick answer would be IO-TKI, but maybe we should know if this patient, because it has, for example, sarcomatoid features, because those are the kind of patients that usually have sarcomatoid features. So if it had, I would maybe go for IO-IO.
Okay, so that's fair. So if you see sarcomatoid features, maybe you lean towards IO-IO, likely in this scenario with this aggressive disease pattern, IO-TKI. I tend to agree with that approach. Okay, now Pedro, tough question for you. What's the best IO-TKI regimen?
That's for you.
Go for it.
Thank you, Monty.
Oh no, I have some for you too, Christina.
So obviously, there's a reason why we've been debating this topic every single meeting on kidney cancer. So I don't think I have the answer. I think activity of the IO-TKI is dose dependent, as well as the safety. Mm-hmm. So the higher dose of TKI I'll use, the higher chances of success measured by response rate, perhaps even PFS. The lower dose you go, the more tolerability you're going to get, but likely a little bit less. You're gonna pay a little bit on the activity. I think they're more alike than different, and I think some of the dose changes might explain some of the differences that we see. And so the bottom line is, I'm not convinced there's one combo better than the others. I think using it well is probably where we see a difference. If I use a combo very well and I know exactly how to escalate or titrate the dose of the TKI down, or allow the patient to be on the exposure to the best tolerated, especially on the TKI, because we don't do that on the IO component. I think that's where we see the delta of the benefit between what we do when you're very, very comfortable versus when you do this once a year, you're not as comfortable, you don't use this combination as always, because in most tumors we don't use an IO-TKI. So I do think the familiarity with a combo plays the major role here. to answer your
So
question.
you didn't really give me an answer, but I will accept that. I'll totally accept that. That's fine. I'll make a pitch. I tend to use Cabo Nivo in this setting. I think between the regimens, I think that with Len Pembro, my observation has been that very few people in the community practice surrounding me are actually getting the 20 milligrams up front, paired with pembrolizumab. They're usually starting at sort of a suboptimal dose. With Cabo, I think that 40 milligram dosing in the upfront setting makes all the difference in the world and makes the regimen a lot more tolerable. So that sort of tends to be my go-to. But well said. I mean, I think that when you find a regimen that you're comfortable with, it's reasonable to go to it. Okay, Christine, I promised you a hard question. Okay, so patient comes into your practice. This isn't the hard question. This is the lead up to it. Okay, let's say a patient gets adjuvant pembrolizumab. Okay, for localized high-risk disease, and within about 9 months or so, progresses on treatment. What would you offer them in that context?
9 months is a tricky question.
Yeah.
So,
9 months into therapy, they're still on treatment and they progress at 9 months.
during
During
pembrolizumab,
Yeah. Mm-hmm.
then I would go for a TKI,
Which one?
probably cabozantinib.
Cabozantinib. Okay. So that was my softball question for you. What if that patient progresses on the combination of belzutifan and pembrolizumab? We might see that in the near future. So a patient gets on pembrolizumab and belzutifan, progresses at the 9-month mark. What are you going to offer that patient?
Cabozantinib.
Still cabozantinib. Okay, very good.
I don't have anything like, you don't have data about pembrolizumab. You will not have data about after pembrolizumab, belzutifan, so choose a good TKI and use it well. So
So that wasn't the hard question either. The hard question is this one. So the patient
I'm scared now.
So the patient gets pembrolizumab and belzutifan.
Okay.
They progress. They go on to cabozantinib. They progress on that after another 9 months or so. Where do you resequence belzutifan in the lineage, or do you use it at all in that setting?
Oof.
What's going to happen?
I can reply whatever because we don't have data for this. I wouldn't retreat the patient with belzutifan, probably because he progressed on belzutifan. He progressed
Okay.
during the 9 months of belzutifan. So I would probably go for another TKI or everolimus, for example.
Okay, that's fair. I think that makes sense. Pedro, I'm going to throw the same scenario to you. So Pembro, belzutifan, I'm getting all the names mixed up here. Pembro, belzutifan, adjuvant, progresses on that, goes on to cabozantinib monotherapy. Totally agree. Reasonable choice, goes on to that, then progresses.
Can I add an exception to that?
Oh, are you going to test me now? Okay, go ahead.
I do think, I just want to, as a reminder, we should always think about local treatments. Right?
Okay.
And actually, the adjuvant studies have a little bit higher use of local therapies that one would anticipate.
Yeah.
So, and we all have those patients. So when they progress while on Pembro or soon after being done with Pembro, it depends on the progression or the recurrence, right? Is the recurrence, is one spot, or is it systemic, or you have those tiny millimeter lung nodules that are now growing and you absolutely have systemic disease, or you're having a solitary oligo progression. I do think very comfortably that if you have an oligo recurrence or oligo progression, I would think about actually offering local therapy to a patient and whether complete the immuno or continue on surveillance and treat with a new line of therapy systemically upon clear progression.
Okay, so belzutifan's not going to enter back in too soon. Is that fair? Or what,
Right, and this would be true whether you have pembrol bel for if you're an early adopter of in the adjuvant setting or pembro monotherapy. So I wouldn't jump on the next systemic line of therapy. Let's say if the patient has oligo recurrence in the lung.
Okay.
Right, I probably would offer radiosurgery, and then stay, hold tight. Check him with regular scans. I wouldn't necessarily offer him a new line of therapy for oligo recurrence.
Okay.
That would be my only
That's fair.
caveat
That's
to
fair.
that.
Yeah, okay, very good. Okay, so this patient who you see on the screen over here, let's forget about the adjuvant scenario for a second, comes in with metastatic aggressive disease in the liver, right? And in this scenario, the patient comes and sees me, we don't really hit it off, so they fly to Spain and see you, Christina, and you recheck the pathology, and it's not clear cell, it's actually papillary. What would you offer that patient as frontline therapy?
So then I would go for Nivocab or Lempem.
Nivocab or Lenpem. What about you?
Yeah, I would do the same. Definitely Cabo Nivo, Lempem. I'm a little more comfortable with Cabo Nivo, so that would be my preference, but absolutely one of the two.
Okay, okay, that makes sense. That makes sense. Now let's change this up a little bit. Let's say the patient doesn't feel comfortable with you, Christina. I don't know why, but let's say they fly to Cleveland.
I'm adorable.
I think so too. So let's say the patient flies to Cleveland and sees you, and in fact you revise the pathology again, and it's chromophobe kidney cancer.
Right.
What are you going to treat with there? So this is metastatic aggressive chromophobe RCC.
Yeah, so that's tough. So the phase 2 data that you have with Cabo-Nivo and LAMP-PAM, you do have responses, and you have stable disease with Cabo-Nivo, and you have responses with LAMP-PAM. So to me, those stable disease in chromophobe is not a bad thing. So I would probably still offer IO-TKI, and I would do genetics on the patient, find out if he has PTEN, et cetera, but that's a separate conversation because there might be a role for an mTOR inhibitor in there. But let's assume it isn't. I might do Cabo-Nivo with the thought process, might do LAMP-F afterwards. Okay. So that could be an approach. But I would still debate between the Cabo-Nivo and LAMP-PAM in that situation. In some cases where you might see, a PTEN, et cetera, I have done LAMP-F as well for chromophobe.
Interesting. Okay, that's a good point. I think that's an important subtlety because it brings up this concept of doing genomic profiling in all of our patients with metastatic non-clear cell kidney cancer.
And if I may make another point, because you asked about this patient, I think most of us would agree, this first shot of a goal might be the last one, right? If we're not successful, so probably most of us will do an IO-TKI. This would be a patient where we probably would not send out the tissue for gene expression signature on the OPTIC trial because we don't have the luxury of waiting 3-4 weeks to get those results to then decide if it's an inflammatory signature and do Ipi/Nivo. Yeah. So in the absence of sarcomatoid, probably most of the community would go towards an IO-TKI with the thought process of, PD as best response in the single digit with Cabo-Nivo, LAMP-PAM. We're probably going to do that and then deal with that, and make sure the patient actually survives.
Yeah, interesting. So let's say a patient comes to see you, Christina. This is my last tough question before we move into some more tough questions, actually. But let's say a patient comes in to see you. They have pathologic T4 disease, no sarcomatoid features, okay, at the time of surgery, and they're pure papillary. Okay, patient comes in and says, I really want to get adjuvant pembrolizumab. What would you do?
Oof. I think we don't have enough data to do it. Can I offer him durvalumab or not?
Durvalumab, sure.
So at least we have the Rampart trial included those patients with papillary characteristic papillary tumors, but I maybe would go for durvalumab.
I like that idea. I didn't think of that, but maybe that's a place for it. What do you think, Pedro?
I might ask him to fly to Madrid to do it. I probably would still stick with observation as of today. The activity of dual IO, it's less obvious. Yes, we have some data, particularly with Ipi/Nivo. I think on the Rampart, you're absolutely right. You do have an unclear cell cohort there. I feel like we might be slicing at some point because we start losing numbers there, right? So I don't think I've seen enough to be convinced with dual IO in the advanced setting for non-clear cell. And in adjuvant, I think we're pushing it forward. So in the DFS, no OS, et cetera, I probably would stick with observation for now.
Very good. Okay. Last scenario here. Let's imagine a more typical context for this particular disease type. 25-year-old patient comes into your clinic. Okay, they have a history of sickle cell trait, and you identify them as having metastatic renal medullary cancer. RMC. Yeah. This is a really tough one, and we have a lot of trainees. I see the San Diego team here in the room, my City of Hope team, the Utah team, Michigan, Spain. So what would you do in that context for metastatic renal medullary?
Yeah, so it's very hard to treat. So the current guidelines, I think, there's an RC group, by the way, that partners with KCA. So shout out to RMC, Nizar Tanir and Pavlos do a great job leading that. So the guy, a lot of times I pick up the phone and call Nizar or Pavlos, but so multi-chemotherapy has been the approach. Thinking about the bulk in the cases of responses has been appropriately. So in those cases, I've been considering multi-chemo, approach up front with the thought process of local control afterwards if they're responding. And there's some debate what type of therapies you're going to be using, platinum, doxo, jam, etc. Right? And I tend to use a little bit the strategy of Anderson, but some variants at times. But it's extremely rare, and I would just advocate. I'm not aware of a trial as of today, but sometimes some groups, you, Monty, might at some point, or Anderson might, and those are the cases I think would absolutely, if there's a clinical trial available, I would absolutely recommend that over any other option.
Well said. I think the one important teaching point around renal medullary cancer is that it's one of those cancer types where you actually really want to actively avoid IO. That's one of the things that Pavlos has taught me, is that it can really sort of accelerate the disease, cause this sort of hyperprogression, if you will.
There's a recent publication exactly on that point, Monty.
Yeah, exactly. So if everyone could take a moment just again to respond to this polling item here. I'll pull up again this QR code. It'll just take a moment. While you're doing that, I'd like to just give another quick note on the KCA. There's lots of educational events that the group hosts. They're all listed at the website, really easy to find. Lots of frequently asked questions videos, and these are actually really helpful tools for those of you in clinical practice who really want to give more in-depth explanations to patients. And the educational materials are bar none some of the best that I've seen. So I would definitely refer you to those. And with that, it's my pleasure to introduce Dr. Suarez, MD, PhD. She's the head of the genitourinary CNS sarcoma. I didn't realize this, AYA and cancers of unknown primary site unit, all of that, huh? Wow, okay. That might be a new development. Well, welcome, and thank you for doing this.
Thank you very much, Monty, and thank you very much for the invitation. It's a pleasure being here. So yeah, we are going to talk about sequence now. So when patients progress to first line, there are many factors to take into account. One are the biological factors. So what was the first line? What was the treatment used in first line? Was an IO-IO? Was an IO-TKI? How deep and durable was the response with this first line? And how rapid was the progression? Obviously, we need to take into account patient factors. So what is the patient's age and the performance status? Is the patient symptomatic or not? Did the patient experience a significant toxicity with the previous treatment? How did he manage this toxicity? And what are the comorbidities of the patient? And obviously, we always need to have shared decisions with the patient. So what are the patient's goals? This is something important to discuss with them. It's not the same a young patient that is working than an old patient that has maybe wants to prioritize quality of life. So what is the prognosis of the disease, and the understanding of the patient of this prognosis? What is the patient's tolerance to the adverse events? What support system the patient has? It's not saying there are very many differences among countries and among US and Europe. And how prepared are they to assist and to handle with these potential challenges? So this is the current options we have. If the first line was IO and nivolumab, then we can use a TKI in second line and a TKI or belzutifan in third line. If the patient has received IO TKI, then we can use a TKI that has not been used before or belzutifan, and the same in third line. And if the patient has received just VEGF TKI, then we can go for IO or for TKI. So the TKI with the highest evidence in the sequence is cabozantinib. We had many retrospective data with cabozantinib in the sequence, and then we had this Cabo Point trial. The Cabo Point trial is a phase 2 prospective trial, including two different cohorts. Cohort A were patients that had received in the first line IO-IO, ipi-nivo, and cohort B were patients that had received in the first line IO-TKI. And the primary endpoint was the overall response rate in the cohort A, in the IO-IO cohort. So as you can see, patients with cabozantinib after nivo-ipi had an overall response rate of 42%, but a disease control rate of almost 90%. Similar data in cohort B, just 10% of the patients showing progression disease. So it looks like a very good second line. So recently, at last ESMO, the LENCAO trial was presented. This is a phase 2 trial comparing lenvatinib, everolimus versus cabozantinib in the second line. So lenvatinib, everolimus, with 40 patients in each arm, demonstrated a higher progression PFS and a higher overall response rate, 52% versus 38%, but also a higher toxicity. So the question comes and would be, maybe we can discuss this later, will this combination change practice from a standard of care of cabozantinib with this trial with 80 patients? Something we could discuss. And we also had tivozanib. This is an old study, the TIVO3 trial, tivozanib versus sorafenib. This trial was conducted in the TKI era, although some patients, less than 20% of patients, had received previous immunotherapy. So the trial demonstrated a benefit in PFS for cabozantinib, with a trend in benefit for OS. Tivozanib also demonstrated better tolerability, demonstrated fewer all-grade and grade 3 treatment-related adverse events, and fewer dose reductions. So cabozantinib is a TKI that can be also used in the sequence, and we need to remember we have this option. So we are going to see, I think maybe Monty can explain better than me because it's a word from his institution, but you can see this abstract on Saturday about real-world with tivozanib. Almost 130 patients included, and when they showed is that disease control rate higher than 80%, and median OS higher than 13 months. So similar results to those observed in the phase 3 trial. But it has been mentioned before, we have now a new, not now, it's not so new now, mechanism of action, and it's the HIF-2 alpha inhibitors. We know the HIF pathway is central to the pathophysiology of clear cell RCC, and belzutifan is the first-in-class oral HIF-2 alpha inhibitor. So, as you all know, the LIGHTSPARK 005 trial included patients that had already received IO and TKI. Patients had received 3 lines or less of prior treatments, and were randomized to belzutifan or everolimus. The dual primary endpoints were PFS and OS, and it demonstrated a benefit in progression-free survival with no benefit in overall survival. Overall response rate was also higher with belzutifan, 23% versus 3.5%. And I think, this is something very important from this trial, duration of response was much higher in the belzutifan arm, almost 20 months. And we can see a plateau in the course of patients receiving belzutifan. Also, belzutifan demonstrated fewer adverse events. Fewer patients discontinued belzutifan versus everolimus, and median duration of therapy was higher or was longer with belzutifan. Patient-reported outcomes indicated better disease-specific symptoms and quality of life with belzutifan compared to everolimus. Most frequent adverse events, anemia and hypoxia with belzutifan. So what about, we have been talking about TKI, we have been talking about HIF-2 alpha inhibitors, so what about if we combine these two different strategies? So we already have some data about combination of belzutifan plus lenvatinib. This is a Keymaker U03B trial. It's a multi-arm trial with different combinations, and the belzutifan lenvatinib combination showed an overall response rate of 50% with a median OS of higher than 36 months. So it looks like a very promising combination. And this combination has been explored in the LIGHTSPARK 011 trial. In the LIGHTSPARK 011 trial, patients that had received immunotherapy and both in the metastatic setting or in the neoadjuvant or adjuvant setting, were randomized to belzutifan plus lenvatinib versus cabozantinib. The primary endpoints were progression-free survival and OS. So go to the, we will see the data during during this ASCO GU on Saturday. I recommend you not to miss it. But we know from a press release that there is a benefit statistically significant and clinically meaningful benefit in improvement in progression-free survival and in overall response rate, and a trend for overall survival. So we will see the results presented by Robert Motzer on Saturday. So belzutifan, it's also been explored with sanzalitinib. Pedro explained that sanzalitinib, it looks like a great TKI. So the LIGHTSPAR 033 trial, it's including patients that have progressed to adjuvant pembrolizumab, so just in the adjuvant setting, and is randomizing patients to zanza plus belzutifan versus cabozantinib. The primary endpoint is PFS and OS. And in parallel with this trial, the phase 1b/2 trial with different doses is being conducted, and you can see the abstract for trials in progress on Saturday as well. So what about other combinations? So from preclinical data, we know that belzutifan and CDK inhibitors, CDK4/6 in this case, can be synergistic. So it's in the LIGHTSPAR 024 trial. This combination has been explored with belzutifan plus palbociclib in pretreated patients, and what the conclusion is that the combination is manageable. So we will see also rapid oral presentation from David McDermott on Saturday. So lots of data for RCC during this ASCO. So we are always seeking biomarkers in RCC. We are not succeeding too much sometimes. But yeah, as mentioned, we can see that some patients can achieve big benefit from belzutifan. And these two abstracts that, again, will be presented next Saturday, are exploring different biomarkers for belzutifan. So the first one explored or studied patients coming from the LIGHTSPAR 13 trial, and what demonstrated that HIF-2 alpha TPS and HS score can potentially be associated with progression-free survival. BAP1 mutation can potentially be predictive or of improved overall response rate, and molecular subtypes and other related RCC signatures and VHL mutation showed no association with overall response rate. So we expected that these molecular subtypes, or at least VHL mutation, can have some relationship, but it looks like not in this trial. We also have some data from belzutifan, retrospective data from patients treated with belzutifan. And what we can see in this work is that responders exhibited enrichment of the PI3K, AKT, mTOR pathway and DNA damage response alterations. So go and see the abstracts, because it's going to be very interesting to look at that. Another HIF-2 alpha inhibitor, casdatifan, is also on his way. So we have preliminary data from the phase 1 trial in monotherapy showing a 33% of overall response rate, and also in combination with cabozantinib showing an overall response rate of 46% and with a manageable adverse event profile. So casdatifan, it's also been explored in combination with cabozantinib in patients pretreated with immunotherapy. Both, in this case, it can be adjuvant setting or metastatic setting, and patients are being randomized 2:1 to casdatifan, cabozantinib versus placebo cabozantinib. The primary endpoint is PFS. And some efforts have been done, and we have some data about biomarkers with casdatifan, and which is interesting that this work showed that deep serum EPO reduction was observed or was associated with a higher response rate. So this is also interesting, and it looks like an easy biomarker to measure. But it's predictive. We would need something prognostic, maybe. Sorry, predictive, but once you started the treatment, so.
Right.
So yeah, so again, as we move on, please answer a follow-up polling question.
Great.
Yes?
Yeah, I think we probably keep going.
So I think, Monty, you can discuss the case of Jose.
Hey, awesome. And you finished up well ahead of time, so I have lots of time for tough questions now. Perfect. All right, thank you, Christina. That was an excellent talk.
Sorry,
Thank
Pedro.
That's great.
Okay, so and we actually have a ton of audience questions as well, so we certainly have, I think, plenty of time to address that too. Okay, so we're going to first consider a patient who progresses on dual IO. Okay, these are questions that we've, frankly speaking, answered in previous years, but let's do it. Okay, patient progresses on Nivo-IPI. What would you typically offer in that setting, Christina?
Nivo-IPI. So today, cabozantinib. On Sunday, I don't know if I will offer lenvatinib, belzutifan.
Okay, let's talk about that. Let's talk about that. So, we've seen the data in the press release at this point in time. They've signified that there's a PFS benefit. I think they suggest, a trend in overall survival and so forth there. What are your thoughts, around whether or not you would render this therapy in that particular setting? Let's say, the patient comes in and sees you and says, look, I'd like to maybe proceed with lenvatinib at 10 milligrams instead of 20 milligrams just because of toxicity concerns. Would you move forward with that in the second line setting, or would you really insist on giving 20 milligrams?
I insist on giving 20 milligrams.
Insist
and then,
on 20.
Yeah, I just see the patient very often at the beginning and be very aware if I need to reduce the dose, but I start with 20 milligrams dose.
Insist on 20. What do you think, Pedro? A patient comes in the same setting, gets Nivo-IPI up front and says to you, look, I just don't think I can tolerate the 20 milligram dose. What do you think about starting on 10 or 14?
Yeah, I think my go-to probably Cabo. I do think of Lenv-Av as a default, assuming before we've seen the data. I do Lenv-Av if I able to stick to the full dose.
Okay.
You run an elegant study demonstrating a non-inferiority, I guess, of lowering the dose of Lenv, right? So you basically don't see the same efficacy signal, and yet it's not that patients are doing a lot better from the safety perspective. That's actually interesting from the study you ran. So if I think a patient cannot tolerate or having a conversation, Cabo default plan, Lenv-Av for the feet that are looking for response, etc. Maybe Lenv-Bel in the field for the same logic without those reductions. And then frail patients, maybe TiVo would be a different consideration.
Okay. No, that's really helpful. Okay, now I'll turn to you, Pedro. Pedro, patient gets IO-TKI in the frontline setting and then progresses. What is the best second-line strategy?
Well,
One
I'm
answer.
not sure we know that. I think it depends on the IO-TKI, right? Because we don't in general we don't recycle the same TKI upon progression. Although there's a little bit of data that if you're able to dose titrate, you can salvage some of the patients, right? We saw that with Axi-Pembro, for instance. Patients are doing great, no symptoms at all on Axi-5. You could potentially escalate the dose of Axi, but that's for a selected group of individuals. So if patient got Cabo-Nivo frontline, for instance, then I'll be more towards. I'm going to be leaning towards. Am I going to consider Lenv-Bel? Am I going to consider Lenv-Av? I haven't seen the data for Lenv-Bel. If assuming the patient can tolerate and wants the best treatment efficacy-wise out there, and that would probably be my thought process. If patient got Lenv-Bam, probably Cabo would be the default plan for me. I don't do IO re-challenge for most of my patients.
Okay.
Based on T-Nivo and based on Contact 3. And then if patient got Axi-Pembro, I think you have the same conversation around, are you going to do Cabo, are you going to do Lenv-Bel, are you going to do Lenv-Av, are you going to have frail patients doing TiVo-like?
Yeah, no, I think that's very reasonable. Let's just sort of take this scenario one step further. Let's say the patient, comes to you after progressing on Cabo-Nivo specifically. What would you offer in that setting as sort of a second line approach?
Then probably we wait for the data, but probably LEM, belzutifan.
Len-belzutifan as opposed to len-everolimus. Does len-everolimus kind of maybe go away at this point, in your opinion?
So I don't know. We need to see the data. Maybe do indirect comparisons.
I know this is tough in the absence of
Yeah,
actually
but-
seeing the
But
data
I
itself.
think Bell is better tolerated than the everolimus, so belzutifan is better tolerated than the everolimus. And
Right, right. There's one study, I think we may have touched on it very briefly. It's called the Pedigree Trial. So this takes patients and looks at Nivo-IPI up front, right? And in patients who, don't achieve a CR but also don't have immediate progression, there's this randomization to potentially add cabozantinib to nivolumab. Let's just imagine a circumstance where, that study is positive and that becomes a relevant treatment option. Where does that sort of sit with sort of transitioning therapy to a different second-line regimen altogether? What do you think, Pedro?
I think it'll be an approach that's not going to be that different from a Cabo-Nivo frontline, right? Because
Okay.
I think it will be positive for PFS, right? If we bring a TKI in a maintenance setting with Nivo, Cabo-Nivo versus Nivo monotherapy, I don't see a world where the PFS won't be positive for the Cabo-Nivo arm. The question is overall survival, right? Is it going to change practice? Because if we don't see a survival signal, then so what we're doing with that trial is we're basically bringing the TKI sooner instead of doing it upon progression, right?
Yeah.
Essentially. So if we don't see an OS, I doubt they'll change practice.
Okay.
And so essentially, but if it's positive and people do it, then I think we're going to be thinking of it as a post-Cabo-Nivo setting, right?
Got it.
Scenario.
Yeah. Okay.
And Monty, I do see a world where with Lenv-Bel being positive, in a magnitude similar to Lenv-Ev, although small study, 80-patient study, but let's assume, okay, it's going to be available. I do see a world where folks will do Lenv-Ev because they've has been around longer, to save the Bel as monotherapy instead of doing EV monotherapy. Because if you do Lenv-Bel, then people don't really like EV. They see it as like a pre-hospice therapy by itself, especially in the community, right?
Okay.
Where the uptake of belzutifan hasn't been as fast as academia. So I do see a world where some colleagues out there might still consider saying, you know what, let me, Bel is approved by itself. I can do Lenv-Bel, I can do Lenv-Ev, and I can do Bel. And so they don't lose a line. Whereas if the other way around, then they're left with EV by itself, right?
I hadn't really thought about it that way. I mean, I guess that makes a lot of sense. Let's envision that Cabo-Nivo upfront patient, right, who we just brought up a moment ago. What about tivozanib as an option in that second-line setting? What do you think about that?
Yeah, I do think I do it for selected patients. Frail, they value quality of life, they want to be on therapy, but they're worried about side effects. I'm concerned. I don't think, I'm worried about the toxicity. Tivo is really a well-tolerated agent, right? I mean, if you pay attention to the high blood pressure and you proactively manage that, it's really easy to do, and it has activity. I mean, the T-Nivo, Monty, you did a subgroup analysis on that T-Nivo based on Tivo monotherapy on patients who progress on dual IO, so TKI naive population, which is not what you asked me. You asked me a post-Cabo-Nivo, right? So you can absolutely on label do a post two systemic therapies, one Cabo and one Nivo. But even in the TKI naive, he has activity over 9 months PFS. So I'm not shocked in using Tivo in the second line, whether it's a post-IO TKI, particularly in patients that, as I said, I'm balancing the toxicity and efficacy, and I'm not really sure they're going to be handled, some TKIs who are prone to perhaps give a little more side effects.
Got it. Christina, you had a lot of really interesting elements related to biomarkers here. There's some questions, from the audience related to biomarkers. Specifically, I was wondering about the role of EPO. It's something that I've actually become more and more comfortable sort of giving ESAs specifically in the context of patients receiving belzutifan. I have no reservations about propping up, the hemoglobin using that strategy. But do you follow EPO levels themselves? You pointed out the casdatifan data where it seemed to have some predictive role.
No, we usually follow hemoglobin, and then we start EPO when hemoglobin is below 10.
Okay.
So
that's generally my practice too. What about you, Pedro?
Yeah, I tend to use the cutoff of 9, unless the patient is symptomatic in the 9s. So it's an on-target effect, right? So it's a learning point for us. I think we're learning more and more to use EPO. It's something that I think we've stayed away from, right, for a long time, and now we're learning. I'm actually learning, having this conversation with my pharmacist just last week. We were basically saying we need to put up a cheat sheet for all of us to kind of come up with our own guidelines how to do it, because that actually, it's funny, because if you look at the trials, right, there's a learning curve, including for investigators, where in the beginning people were dropping the dose of the HIF-2 alpha, whether it's Bell or others, and then as time went by, people are more comfortable using more EPOs, as a consequence, not dropping the dose or discontinue the therapy. So it's an interesting observation. I agree. I'm glad you brought that up. And I do think we're all learning how to use EPO in the context of HIF-2 alpha inhibition.
The one thing I often kick myself about is not checking iron levels more often, and that's something, my pharmacy team has gotten me in the mode of doing now whenever I'm prescribing belzutifan. So are you guys doing the same, checking, iron saturation, iron levels, et cetera?
As part of our protocol, yes. So it's almost in the guideline, I guess. But yes, it's to rule out other causes of anemia. That includes, usually is the iron workup, which includes the iron. Sometimes we also drop the vitamins in there, the folate and the B12. But you're right, Monty. Like, it's something that in the beginning I had to be reminded a few times to do it. I'm better now.
Do you use iron with the EPO?
I'm sorry?
Do you use iron with the EPO?
Well, if you have an iron deficiency, then we'll fix it.
Yeah, indeed. A lot of great questions coming through. This is a really important one. So we've talked a lot about the LightSpark 11 data with respect to what we know already, with the caveat that none of us have really seen the data in its full form at this point. What toxicities are you going to be looking out for in that trial? Are you going to look at that toxicity table and say, okay, it's the amalgam of all grade 3, 4 toxicity between the two arms that's relevant? Are you going to be focused on diarrhea, hand-foot syndrome? How are you going to be looking at the tox data for Len-Bel versus Cabo? It's a tough question. Pedro, maybe I'll throw it to you first.
Thank you.
Sure.
Yeah, it's hard to say. I mean, they are combinable, right? We know that, right? So, I don't think we're going to find very surprising toxicity. I do expect to see the combo be more toxic than Cabo. I do. And for some people, some people might look at the grade 2 diarrheas and might give them some pause. Yeah. Some people might look at the 15% hypoxia and give them some pause. Some people look at 80% anemias and give them some pause. Some people will look at the dose reductions happening, 50%, 60%, I'm guessing, and they give them some pause. So I do think how we interpret that will depend on how comfortable we already are using it, and I think we're going to use that as justification to do it or not to do it as much.
Yeah, I think that's a really beautiful point. There are those side effects that perhaps all of us as clinicians are more comfortable managing, others where, I think we get a little frightened, to be honest with you. Well, Christina, what do you think?
Yeah, I think that I expect not to see many difference in the TKI adverse events due to a TKI. We will see more anemia for sure in the LEM and the belzutifan arm. And yeah, the same, like, depends what you feel comfortable with or not, but we'll see.
Yeah. So, one question I always like to close with, and I would love to, take questions from the audience too at this point, is what do you feel is the most exciting therapy in the pipeline today for kidney cancer? If you had to pick one, maybe I'll let you pick two, but not 10. If you could maybe just give us your best guess as to what you think might be moving forward in the field. Any takers for that question? Pedro, can I throw that to you first?
Well, my answer is going to be, comes with a caveat. I'm biased because I was involved in the 3 or 4. If that phase 3 trial is positive, we'll change practice in the non-clear cell arena. So I'm excited to see data with Zanza. And I actually think if that trial is positive, I do see many of us bringing the Zanza from non-clear cell to the clear cell arena. So I see a dual impact there. And then, for obvious reasons, I'm excited to see what happens with the BioFront trial with the CBM 588 and data that you generated, Monty. And and I do think the impact can be for kidney cancer patients and then beyond kidney cancer. And maybe we're gonna see a wave of gut microbiome impacting strategies to squeeze the activity or enhancing the activity or immune strategies that we currently use.
Yeah, that's great. And I'll just reiterate for everybody in the audience, although Pedro, you were very clear on this, the BioFront study is actually going to look at any IO-based regimen. So it could be Cabo-Nivo, Axi-Pembro, Nivo-Ipi, plus or minus CBM-588. And that's going to be a really important study open throughout the U.S. through the cooperative group mechanism. So, if you do have a space in your frontline portfolio for a trial, please, please, please get behind that one. I think it's really, really going to be an important study. Christina, can I turn to you for the same question? The agent you're most excited about?
I think I'm going to reply the same. So I'm biased as well because I'm very involved. The Stellar 304 can be practice changing, and this is a first phase 3 randomized phase 3 trial in non-clear cell. So we really need a good combination for non-clear cell. And yeah, I think the BioFront is a very, very interesting trial, and the data you have from the phase 1 trial are very, very promising. So yeah, I would say these two.
Excellent. Yeah, no, I'm really...
And again, and the optic trial, I want to see I'm waiting to see the EP-Nivo arm. I think the optic trial, it's very, very really appealing because you are doing tailored medicine. So I think it's a field we should move to, like choosing the treatment by molecular alteration.
Okay, so I'm glad you brought that up. My last tough question for the night.
What is yours, Monty?
What's that?
What is yours?
The most
What's your
exciting agent. Oh, okay. Well, I'll share with you. I have to agree with you guys. I mean, we the three of us do so much work together on the investigational front. I'm equally excited about Stellar 304, which all three of us are very integrally involved in. Zanzalintinib with nivolumab versus sunitinib. Important study in the non-clear cell space. The first phase 3 clinical trial that's happening, which I'm so grateful to the sponsors for supporting. And certainly BioFront, which you've gotten behind, Pedro, and really, taken an amazing lead on. I'm so proud of you. I think that's going to be a very important study. I did want to give one shout out to a phase 1 study that's ongoing right now, looking at an agent called XMAB or XMAB 819. We showcased some of this data actually at the Kidney Cancer Association last year. They were kind enough to let us submit a late-breaking abstract. Take a look at that. It's a bispecific, and it's directed against a target that we actually haven't mentioned in the meeting at all today. It's called ENPP3. But this particular target is expressed at really, really high levels in clear cell kidney cancer, not on adjacent tissue. It's at moderately high levels in papillary kidney cancer, in fact, too, not in adjacent normal tissue. And there's some degree of expression in lung cancer and colorectal cancer as well, but kidney cancer is really going to be a standout disease. Last year, we reported some really robust responses in very heavily pretreated patients. So I think that therapy is actually going to make, it's one to watch out for. I think it's going to make a big dent, but we'll have to wait and see.
Wonderful.
Yeah. Well, I have to tell you, we're coming to the close of the evening. I'm certainly more than happy to take any questions from the audience. We have a roving microphone. But on the same note, it's the first day of ASCO GU, and I know everyone's itching to get to the bar on the 39th floor after this. I know I am. So with that, I want everyone to maybe just take one last moment to submit any last-minute questions that we can answer after the fact. And then finally, I want to thank the audience and our sponsors tonight for supporting such a wonderful program. Thank you all for being here.
Thank you. Great job, Monty.
Great job.
Thanks.
You are very good, Chair.
Oh,